Today we will go to a new topic in neuro-ophthalmology, papilledema. Okay, so what is papilledema? It is defined as it is the optic disc swelling when there is an increase in the intracranial pressure, and it is usually bilateral, and although it can be asymmetrical. Okay, so other forms of disc swelling which is caused either by a local or systemic process should be designated with either to any other presumed etiology like the anterior ischemic optic neuropathy or the optic neuritis, or any other causes of optic disc swelling or optic disc edema. Okay, so you can see here the margins. This is the optic disc, optic nerve head, where the margins are blurred. I'm sure now you all know by now what a normal optic disc or optic nerve head looks like. The principal pathophysiology of this swelling is can be the blockage of the exoplasmic transport at the prelaminar region, and any elevated cerebrospinal fluid pressure produces an exoplasmic stasis in the optic nerve head, which can lead to a swelling of the optic disc and secondary vascular changes at the disc surface. And the degree of papilledema varies with the ease of access between the meningeal spaces within the cranium and around the optic nerve. So you all know that the CSF is formed from the choroid plexus, where it then drains, leaves the lateral choroid plexus in the ventricles, and then it leaves the lateral ventricle and then enters the third nerve, then enters the third ventricle through the foramen of Monro, and from there it flows to the Sylvian aqueduct into the fourth ventricle, and from the fourth ventricle it enters into the subarachnoid space, and absorption is through the arachnoid villi in the cerebral venous system. And since you know that the optic nerve is also covered by the meninges, so you have the CSF also, which is present there. So this is a normal how an optic nerve looks like. Okay, when there's papilledema, this is what happens, and this leads to swelling of the optic disc when there is an elevated CSF pressure. So here again, this is a normal optic disc, just to remind you all, and this is when there are blurred margins. Okay, so this is what papilledema looks like. So what are the causes? First, when we say what is disc edema? Okay, so optic disc edema, you have to differentiate the true edema from the pseudopapilledema first. So these causes of pseudopapilledema can be drusen, optic disc drusen, any tilted disc, any crowded disc. Then the causes of true disc swelling are when there's an increase in intracranial pressure. Then if there's any inflammation like papillitis, neuroretinitis, any ocular diseases like uveitis, okay, then any orbital causes, okay, so you can have like any tumors, so orbital cellulitis, any vascular causes like AION, CRVO, any toxic causes, any metabolic causes, any nutritional deficiencies. Okay, so these can be unilateral, then the bilateral, so you can be unilateral and bilateral, so you can divide them where the causes can be either unilateral or bilateral. So if there's a unilateral cause, they can be either, the cause can be either papillitis, any anterior ischemic neuropathy, okay, then any orbital tumors, then optic disc vasculitis, all right, then central retinal venous occlusion, and other causes like ocular hypotony, okay, where there's rapid visual loss without any improvement. Then bilateral causes can be when there's an increase in the intracranial pressure, any hypertension, diabetic, then other metabolic causes, any diabetic papillopathy, advanced Graves' disease, any carotid, any cavernous sinus thrombosis, okay, any other, and then nutritional deficiencies. Then you can have anemia. Okay, so these can be the causes of bilateral disc edema. So what are the conditions which are associated with intracranial pressure and the causes of papilledema? Okay, so so usually all patients of papilledema should be suspected of harboring an intracranial mass, right? So the causes of papilledema usually occur secondary to rise in the intracranial pressure, and this can occur in these conditions. You can have congenital conditions like when there's any craniosynostosis or any aqueductal stenosis, then intracranial space occupying lesions, which can be any brain tumors, any abscess, any tuberculomas, then the space occupying lesions of the cerebellum, the midbrain, and the parieto-occipital region usually produces a higher percentage of papilledema. Then any intracranial infections, okay, if you have meningitis, then obstruction to the CSF absorption via the arachnoid villi, any tumors of the spinal cord, then idiopathic intracranial hypertension, or also known as pseudotumor cerebri. It is a condition which is found in the young obese females on the second or third decades, and it is characterized by headache and papilledema, bilateral papilledema. Then systemic conditions like malignant hypertension or pregnancy-induced hypertension, then any diffuse cerebral edema, which can result from any blunt head trauma. So what are the clinical features? So how do these patients present? Usually the symptoms are generally absent in the initial stages, okay, and vision may be unimpaired for a long time, and this usually implies, especially to the central vision, which may be unaffected, sometimes even if there's a presence of a macular involvement, there's a macular fan, which we will come to later. So what are the features? You have the non-visual manifestations of headache, which may be generalized or localized and can intensify with movement or bending or cuffing, and this can be one of the earliest symptoms. And this headache occurs when there is because of stretching of the meninges. Then nausea and vomiting, which is a projectile type of vomiting. Then there can be other focal neurological deficits, like deterioration of consciousness it depends on the severity. So as the severity worsens, so there can be deterioration of consciousness. We can start first as maybe increase sleepiness, and then later on can become more severe. So now the visual manifestations, they can present with transient visual obscurations, which can last, so history of attacks of transient blackout, okay, and which can last for up to 30 seconds in either one or both eyes, especially in those with established papilledema. Then diplopia, or the horizontal diplopia, is seen when there is a compression or stretching of the abducens nerve, the sixth nerve at the base of the skull. So this is one of the false localizing signs of the sixth nerve palsy. Then you look at the visual, so vision and pupillary reactions are usually normal till the late stages of the disease, when optic atrophy sets in. And when you do a visual field, usually there's a concentric enlargement of the blind spot. And usually even this color vision is also preserved till later, when usually color vision in these cases is preserved in papilledema. So you can differentiate it from the other cause, the optic neuritis as well. So how will you classify papilledema? So according to duration, it can be classified as early, fully developed, or established, chronic, and atrophic. There's a Friesen grading system according to the severity, which grades it from 0 to 5. You can have very early papilledema, then moderate, marked papilledema, and severe papilledema. So let's go according to the duration. So As we know that papilledema is nearly always bilateral, but it may be asymmetrical. So in the early or the incipient papilledema, here the symptoms are absent. The visual acuity is normal. Pupillary reactions are also normal. The ophthalmoscopic features, here if you look, there starts the blurring of the margins, which begins first in the nasal, then the superior, inferior, and the temporal. Then there is a blurring of the peripapillary nerve fiber layer. Then there is absence of spontaneous venous pulsations. These spontaneous venous pulsations are usually seen in at least 80% of patients. Then there is mild hyperemia of the disc. There may be splinter hemorrhage in the peripapillar region, and if you do a visual field test, it is fairly normal. Then the next stage is a stage of established or fully developed papilledema, where the patients present with history of transient visual obscurations in one or both eyes, and this can last for a few seconds. Okay. So what we see here is there's an apparent disc edema. Now you cannot even really be able to make out the disc margins. The physiological cup, which is normally seen, is obliterated. There is marked hyperemia of the disc and blood margin. So this elevation is usually seen up to 1 or 2 millimeters, and you see multiple soft exudates with these and superficial hemorrhages near the disc edges. The veins are tortuous and engorged, and in advanced cases, the disc appears enlarged, and there you can also see these circumferential grayish-white retinal folds, which may develop due to the separation of nerve fibers. These are known as patent lines, P-A-T-O-N, patent lines. Okay, these are seen more temporally, and you also get what is known as a macular fan. Here, in macular fan is usually seen in the younger patients, where small vesicles they form on the superficial retina, okay, and they converge on the fovea. And this is seen in a fan shape, and the apex is towards the fovea. Okay, so you should not confuse it with the macular star. The macular star is mainly composed of these exudates. Then coming to the next stage, which is the chronic papilledema. Here the visual acuity is variable now, is advanced. And this depends on the duration of the papilledema. Pupils are still reacting and usually normal. Now the acute hemorrhages and exudates, they all resolve, and peripapillary edema also is resolved. Now the optic disc appears like a dome of the champagne cork, and you can get small crystalline deposits, also known as corpora amylacea, on the disc surface. Now, so when you do a visual field test, the blind spot enlarges and the field begins to constrict. Atrophic papilledema develops after 6 to 9 months of chronic papilledema, and it is characterized by severe impairment of vision. Your pupillary reflexes now become impaired. There's a grayish discoloration of the optic disc. The retinal arterioles become narrowed and the veins are less congested. The visual field, when you do a test, eventual severe contraction of the field of vision. So all these features of papilledema should also be differentiated from other conditions like papillitis and pseudopapillitis, because you do see these disc features which are very similar. So we have to look at other conditions and other associated symptoms and other associated signs to distinguish these three conditions. You can have to differentiate it from papilledema, also you have to differentiate from papillitis and pseudopapillitis. Okay, so papilledema is usually bilateral. Papillitis can be, we have already discussed papillitis. So papillitis can be unilateral or bilateral, and pseudopapillitis can be unilateral. Visual field, there can be a transient blurred vision, which can later be markedly decreased depending on the severity of the papilledema. Whereas in papillitis, there's sudden marked loss of vision. And pseudopapillitis it depends on the severity of the refractive error. Now, pain and tenderness is absent in papilledema and pseudopapillitis, whereas in papillitis, it is present with ocular movements. So if you have to remember the last week's class to know the features of papillitis. Okay, so when you do a fundus examination, usually papilledema is clear, pseudopapillitis as well is clear, whereas in papillitis, you can get a posterior vitreous haze. The disc color is red and juicy. It's in papilledema, it's more hyperemic in papillitis. In pseudopapillitis, it is reddish in color. Margins are blurred in all three. Peripapilledema is present in both papilledema and papillitis. It is absent in pseudopapillitis. Venous engorgement is more marked in papilledema, less marked in papillitis, and it is not seen in pseudopapillitis. And retinal hemorrhage is more marked in papilledema than in papillitis. It is not seen in pseudopapillitis. Retinal exudates are more seen in papilledema than in papillitis, in the absence of pseudopapillitis. Macular fan, I've already explained. In papilledema, is because of the vesicles. The papillitis, you see a macular star. In pseudopapillitis, there is no involvement of the macula. Then in visual fields, you usually see an enlarged blind spot. Papillitis, you see different types of scotomas. Okay, you have centrocecal, you have a central scotoma, altitudinal, and so on, whatever other types of visual field defects you can see. In pseudopapillitis, it is normal. And you do fundus fluorescent angiography, there is minimal leakage in papillitis, no leakage in pseudopapillitis, and there is leakage in pseudopapilledema. So these three differentials are important. You have to know. Does come as an exam. Okay, so now coming on to the next topic. So optic atrophy the term is usually applied to any condition of the disc following degeneration of the optic nerve in any part from the retina to the lateral geniculate body. So it is a morphologic sequelae of any disease which can cause irreversible damage to the ganglion cells and the axons of the optic nerve. And these diseases which can either include if there's any ischemia, inflammation, compression, infiltration, and trauma. So have a look at this optic disc. You see the normal color is not seen. It is very pale, okay, as you see here. So in the last stage, you have this optic atrophy, okay. So this is known as optic atrophy. So usually when a visual axon is severed, so its ascending part, which is the part which is towards the brain, okay, segment, it disintegrates and disappears in approximately 7 days. This is known as Wallerian degeneration. The portion of the axon which is still connected to the ganglion cell body, it remains viable for at least 3-4 weeks, but then it rapidly degenerates by 6 to 8 weeks. And this is called descending generation, that means towards the eye. And when the completion of this descending degeneration is complete, now the optic disc pallor will appear. So how would you classify according to the ophthalmoscopic appearance? You can have primary, secondary, you can have a consecutive optic atrophy. So in primary, usually there's no ophthalmoscopic evidence of any previous inflammation, and atrophy is either due to any disease in the secondary visual neuron proximal to the disc. So we cannot see any evidence of any local inflammation. So this is known as primary optic atrophy. So when there occurs without any antecedent swelling of the optic nerve head, and it is usually seen by lesions affecting the visual pathway from the retrolaminar portion of the optic nerve to the lateral geniculate body. And the causes are usually any optic neuritis and compression by tumors, any aneurysm, toxic and nutritional optic neuropathies, and trauma. So how is it seen? So usually it is observed as a white flat disc with clearly delineated margins. There's reduction of the number of small blood vessels on the disc surface. This is also known as a Kestenbaum sign. And there is attenuation of the peripapillary blood vessels, and there's thinning of the retinal nerve fiber layer. A secondary optic atrophy, it is preceded by a long-standing swelling of the optic nerve head. It is also called post-neuritic atrophy, and it follows if there's any injury or direct pressure affecting the visual nerve fibers in any part of the cause from the lamina cribrosa to the geniculate body. So like if there is chronic papillary edema, okay, because of raised intracranial pressure, so you see there's edema, and then so you see the changes in the optic nerve. So this is also known as a secondary optic atrophy. So causes can either be chronic papillary edema, AION, and papillitis. So how is it seen? So it is seen as a white or dirty gray, slightly raised disc with poorly delineated margins due to gliosis. There's reduction in the number of vessels, small vessels on the disc again, and you do get these peripapillary chorioretinal folds, again, especially temporal to the disc, which are known as patent lines. And there can be sheathing. Okay, you can see these vessels acquiring this white sheathing of the arterioles and venous tortuosity may be present. Then consecutive optic atrophy, it is usually caused by diseases of the inner retina or its blood supply. And the cause is usually obvious on the fundus examination. So it can, if there's atrophy following extensive retinal photocoagulation, any retinitis pigmentosa, or if there's a prior central retinal artery occlusion. So this is what would cause the optic atrophy. So it is secondary to, it is following these conditions. So the disc appears waxy with a reasonably preserved architecture. And of course, glaucomatous optic atrophy, you know the changes, the difference usually in this type of atrophy and the optic disc, the optic cup is usually is either normal, whereas in glaucomatous optic atrophy, you would see an enlargement of the cup. So it should be larger than this. So this is an advanced, I've put a picture of an advanced optic advanced glaucoma. So and if you have the atrophy, so there'll be total cupping. So the cup is very much enlarged, okay, and the cause will be chronic glaucoma. All right, so I'll just discuss these two chapters. So the clinical features, how do these patients present with optic atrophy? They can be loss of vision, which can be sudden or gradual depending upon the cause. The pupils are usually semi-dilated and direct reflex is sluggish. And visual field loss will vary with the distribution of the nerve fibers which have been damaged. So if you look at the ophthalmoscopic appearance in primary optic atrophy, I've already discussed. Then consecutive, you have waxy appearance. And the edges are not as defined as in primary atrophy. Then post-neuritic, there is a secondary type of optic atrophy. You can see dirty white or blurred margins. In glaucomatous, you have wide cupping of the optic disc. I have forgotten to mention the investigations you would carry out for papilledema. Okay, so in papilledema, mainly you have to do an MRI, okay, to rule out any space occupying lesion. And you can also do an ultrasound B scan to differentiate between papilledema and other causes of the swollen optic disc. And here what we do is we measure the optic nerve sheath diameter. And lumbar puncture usually it is not advisable in case of papilledema until you rule out any space occupying lesion. Okay, so while I'm still remembering, then the treatment of Optic atrophy is mainly to treat the underlying cause, because once atrophy sets in, vision is not, it becomes irreversible. Okay, so you have to differentiate it from also other causes of dyspala, which can be non-pathological or pathological causes. You can have like non-pathological causes like axial myopia, elderly people where there's sclerotic changes, any if there's a large physiological cup with when there is temporal pallor. Then in pathological causes, like if there's any, you have to differentiate this optic atrophy from if there is a coloboma, a disc coloboma. So you may mistake it for seeing it as an atrophy. If there's any hypoplasia, if there's any optic disc pit. So these are the other causes also which you should differentiate from the actual disc pallor. Okay, so I hope you all understand. If you have any questions, you can let me know. So thank you and have a good week.